Thank you, Dr. Folk. We appreciate all of that information. There were so many questions that came in, and you answered many of them in your presentation. Okay, and so to follow up that great presentation, what we'd like to do is ask you some questions that have been submitted by lots of patients, because honestly, this is one of the most requested type of webinars. People with vasculitis get rashes, and we want to know if we're in remission. Is this a sign that we're coming out of remission? Or if we're actively under treatment, are we getting worse? Are we getting better? So I appreciate this so much. And if it's okay, I'm going to jump right into some of the patient questions.
Please.
Okay, the first one is, how common is rosacea with GPA vasculitis with ANCA? Is there anything to be done about it? I've learned to not scrub my face with hot water, but that's about as far as I've gotten.
Yeah, so this is a great example of patients with vasculitis getting things that patients without vasculitis too. Rosacea affects big portions of the population, and they especially affect patients with skin tones that look like mine. The lighter your skin tone, the more likely you get it. There's lots of risk factors for rosacea: sun exposure, genetics. But one thing that I think GPA patients in particular have are some of the medications, especially steroids. Are really good at protecting us from our vasculitis, and they can be critically necessary to preserve our life and well-being. But steroids are well described to accelerate or even cause rosacea. So I would say I see it frequently in patients with GPA, but it has, I think, more to do with kind of the circumstances around having GPA than the disease itself. There's lots to do to treat it. There's lots to do it. The complicated part of answering this question is that there's a lot of different types of rosacea. So it would be a lot easier if I were, I will give non-specific advice, I guess is what I'll say. A good dermatologist can help you with all of this. There's kind of flat red rosacea, which is a little bit more common with steroids. That is difficult to treat. Medications don't do a great job. There are certain cosmetic therapies like lasers that are very, very effective for improving that. Rosacea that has little bumps that look like acne, that's easy to treat with medicines. Medicines like metronidazole can be really helpful. But this is a great time to get in touch with a dermatologist. They definitely can help you with that. The most important thing I'll say is you want to use a lot of sunscreen if you have rosacea. The sun dramatically accelerates the progress of rosacea. So a good sunscreen with SPF 30, used in a moisturizer in the morning and then reapplied anytime you're going to be spending a significant amount of time outside, can be really helpful to stop that progression. Sunscreen needs to be reapplied every 80 minutes. Most people maybe are not aware of that fact. So if you want to use sunscreen appropriately, use it before you're going to be outside for more than 5 or 10 minutes. And make sure you're reapplying that every 80 minutes of continuous sun exposure.
Well, that was some great information. I'm sure just that one thing alone is helpful. But again, as we've always said in these webinars, you need to talk to your actual doctor to get specific information. This next patient asks, this may be a chicken or the egg type of question, but how is skin involvement typically treated in patients with vasculitis? Do you have to treat the underlying vasculitis condition or treat the cutaneous issues, or is it a two-pronged approach?
Yeah, it's a great question, a very nuanced one, and the answer has to be nuanced as well. Vasculitis is a lot of different things. Sometimes what we see in the skin is just the vasculitis itself. Take our first case. The patient only had skin vasculitis. There was nothing going on the inside. In patients where the vasculitis is just in the skin by itself, it comes down to the patient's symptoms. I have plenty of patients that they hear there's a possibility it'll go away. It doesn't bother them very much. They don't want to treat it at all. Sometimes we treat with topicals and compression. Sometimes that's enough. But there are plenty of patients that require more aggressive therapy. So when the skin findings are the vasculitis itself, there's a lot of different ways to answer that. It comes down to the individual patient. Where this question becomes more nuanced are patients with like ANCA-associated vasculitis, where what you see in the skin is the vasculitis. That is truly vasculitis, but it's also elsewhere in the body. So if the patient's systemic involvement is under control, like the kidneys are doing really, really well, but the skin disease is still quite active. There are lots of things a dermatologist can do, or a rheumatologist, or whomever you're being managed, or a nephrologist, as the case may be, can do to control the skin symptoms if they continue to be problematic. You can separate treatment. You can use medicines to control the inside, and then use separate therapies to control the outside. So topical therapies, or a lot of times those medicines that we talked about, like dapsone or colchicine, can be added on top of whatever therapy you're using for the systemic findings. Maybe the patient's using rituximab for their systemic disease, but they still have some skin activity. We can add dapsone right on top of that. So you want that's why the multidisciplinary clinic at UNC is so important, so that when a patient comes in, all these doctors are at their fingertips, so they can ask those questions in one visit and get them all addressed. So most of the time, what we see in the skin is the vasculitis itself, and we can treat it using the same therapies for the systemic disease. But there are cases where the skin disease continues despite that, and we treat it in parallel. You can also get these parallel phenomena. Diseases where the patient has vasculitis, they have skin involvement that is a result of an abnormal immune system, but is not the vasculitis itself. Maybe they have some eczema, or they have that pyoderma gangrenosum. That's where these phenomena are separate. Controlling the vasculitis might not control the other phenomenon, and then we would take specific steps for that skin manifestation. So it's a nuanced question. Yeah, not so much a chicken and an egg, but kind of sometimes it's a flock of chickens in different places, and sometimes it's a chicken and a parrot.
But it's good to know that, because then you're asking your doctor specific questions like, is this part of my vasculitis, or is this something that happened in addition to my vasculitis? So that was a great answer and will help a lot of us. Another patient says, I've been diagnosed with cutaneous polyarteritis nodosa. My concern and question is if cutaneous can or does develop into systemic form of vasculitis where internal organs are affected. How frequently does that happen in cases, and what symptoms or issues could alert me to that happening?
That's a really good question. It's a high level question. Cutaneous only polyarteritis nodosa. The best way to answer this is to say that I think most experts agree that if you are appropriately diagnosed and the people taking care of you did a really good job of looking carefully for internal involvement and they didn't find it, that you can feel pretty confident, and they continue to watch you, you feel pretty confident that your risk is low. The doctors are going to continue to ask the patient a lot of questions of that review of systems that I was just talking about. They're going to ask about belly pain. They're going to ask about nerves. They're going to keep asking and keep checking. They're going to ask the patient to follow their own blood pressure regularly. But there's actually a couple research studies that were done to address this exact question. And kind of the most important one was done at Mayo Clinic, a great place for study and care of vasculitis as well. They did a large study, 70-some patients, and through appropriate diagnosis, none of them developed internal disease. There was another study that was 20-some patients, and they had, I think they had two patients. I think it was 10%, two patients that developed internal disease. But the question is that the way these studies are built has to do with how rare polyarteritis nodosa is. So, we look at that critically, I guess is the best way to say it. When we put those two studies together, I think the key takeaway is that the risk of progression to systemic disease is very, very, very low if you've been diagnosed appropriately. But because that risk is probably not zero, it's probably close to it, but it's not zero, your doctors are going to continue to ask you thoughtful questions about the rest of your body. And if they're doing that, they're following you appropriately. So I think the short answer is we really feel the risk is low based on the research that we have, but doctors will continue to think carefully about that while taking care of you. I tell most of my patients that we keep a close eye on them, that I think that risk is incredibly low, that I have yet to have a patient go from cutaneous only to systemic. I have not seen it. But I try to give my patients peace of mind that regardless of that low risk, we're watching very closely.
Well, Thank you for that. And I, as a vasculitis patient, I can tell you that I totally believe in close follow-up, and it makes me more comfortable in life. So that goes along with everything that I've learned as well. Another patient says, is it possible to make a positive diagnosis of vasculitis strictly from a skin biopsy, or do there have to be other factors involved to be confirmed? I know you talked about this in your presentation, but maybe just reiterate for this
Yeah,
patient.
absolutely. The key thing to remember is that vasculitis is a lot of different things, and many types of vasculitis can absolutely be confirmed by skin biopsy alone. Some types of vasculitis need a little bit further workup. So that's why we always interpret the skin biopsy in the context of the urine analysis, the review of systems, the patient's history, and when indicated, we do some blood work. But yeah, it's absolutely possible to diagnose a lot of different types of vasculitis just by the skin biopsy.
Interesting. So this next question is from Mark, and he says, can skin issues occur from some of the medications we're taking and not from the vasculitis itself? Could it show as an allergic reaction to an immunosuppressant or steroids?
Oh, absolutely. That's a great question. And we have to keep in mind that some of the vasculitis that I see in clinic is caused by a medication itself. Patient gets started on a new blood pressure medicine, and this is incredibly rare. So we don't want people to be stressed about it, but vasculitis can be caused by medicines given for other things. And then you can have a patient with vasculitis can have reactions to medications that show up in the skin. Sure, you can be allergic to them. I've seen patients that get kind of a bumpy rash all over because they're allergic to one of the medicines they took. Some of the medicines over time, like prednisone, can cause weight gain or rosacea, or most interestingly, high-dose steroid use over time can make blood vessels fragile and can cause purpura. It can cause the blood vessels to be leaky. So we'll see patients that have purpura from their steroids. And so a big part of my job is coming in the room and answering the question, is this vasculitis coming back, or is this from the steroids we gave them? And the purpura looks different. The purpura is usually a lot larger. It's not palpable. Vasculitis purpura fades from kind of red purple to brown, and the purpura from leaking blood or bruises kind of fades from purple to yellow green. So there's lots of ways to tell just by looking at it. But yeah, the answer is absolutely yes. And it can make a huge long list of skin changes. Medications can make a huge long list of skin changes that would take too much time to go over. But yeah, absolutely. Great question.
You know, it's so interesting because that is basically the answer to the next question, but I'll let you evaluate it since I'm not the doctor. But does taking high-dose steroids help to treat or reduce further skin issues due to the prednisone? It seems that when my prednisone dose is lowered, my rashes and ulcers become worse.
Yeah, this is a question where the answer to both questions is yes. It can make the vasculitis much better in your skin, but yes, it can cause other issues as well. So prednisone is a double-edged sword. We need it to protect ourselves and keep ourselves healthy, but prednisone can cause its own issues in many organs, bones, eyes, blood, but the skin is the case as well. So we are always very thoughtful about why we use prednisone. And I have a lot of patients that ask me, the prednisone works so well, what do I need another medication for? And the prednisone is to get you quick control and protect your life and well-being. But we transition to another medicine to maintain that improvement. We try to get the prednisone out of the way over time to reduce the risks of the problems that it can cause.
So this next question is, I heard this term when we were doing another webinar, and I hadn't heard it before and haven't heard it since, so I understand why they're asking. In my medical records, I'm listed as having wheals and pruritus. Can the doctor give some details about specific skin issues? You know, like what does that term mean? Wheals. That's another one. We didn't go.
Doctor, you know, one of the funny thing about doctors is we like to use really big words for concepts that already have words. I guess it's to make us feel smart or something. I don't know what it's for. Pruritus means itch. That's what that word means. That's just the medical term for itchiness. I have no idea why the word exists, but we use it a lot. Pruritus, pruritic. Pruritus means itch, pruritic means itchy. So if you see those terms, that's your doctor writing down that one of the things that the patient mentioned was itch. Wheals, W-H-E-A-L-S, that is a That is a descriptive term for the findings we see on the skin to diagnose urticaria. So urticaria, which is another big word for just hives, are defined by the presence of wheals, which are lumps on the skin. It almost looks like somebody injected a little bit of water under the skin and it just kind of inflated in one area. So if you've ever had a PPD test for tuberculosis, there's usually a little wheal there when they're done. So it's just a swelling in the skin. It's a word for a special type of bump that sometimes means urticaria. That's the long and short of it. That's a great question. Yeah, doctors, we speak a different language, and sometimes that can be confusing. So never hesitate to ask your doctor to translate.
Yeah, we appreciate you translating. I wondered that after the webinar that I did. I'm like, I haven't heard that word before, but I'm going to skip a couple of questions and go to one last question. This one is supremely personal for people, and I think it's important to bring it out. The pain and embarrassment from genital ulcers that accompanied my Behçet's has pretty much wrecked my life. Thankfully, I'm blessed with a supportive husband and family, but I'm not even sure they understand this disease and what it does to me. I guess this isn't a question, but just wondering if the doctor has any comments about the emotional, psychological toll from these chronic ulcers. Maybe also treatment, because that's what your specialty would be in this area, but such a personal question.
And such an important and under-recognized issue too. The skin has a lot to do with who we are. It's what makes the first impression when other people see us. It's the way we interact with the outside world. We use our skin to touch. We use our skin to express ourselves. Our facial expressions are communicated through the skin. And the skin is an important part of intimacy and relationships. And vasculitis and so many other diseases can affect them in deep and striking ways that can make patients feel like there's a barrier between them and the outside world, or more importantly, a barrier between them and the people that they want to be close to. And we cannot minimize the impact that involvement of areas that are of any area of the skin, but especially the areas that we use to express ourselves through communication or intimacy. We can't minimize the impact that has on people's lives. So, as doctors, sometimes there's an inclination to really focus on the things that are life-threatening, right? So if the kidneys are filtering and the heart is beating, sometimes as doctors, we call that a success, and we forget to look at other areas that are critically important to the patient. So to most doctors, every aspect of your health functioning the way it should is important to us. And just because the kidneys and the heart and the lungs are doing their thing doesn't mean we stop. So if you're safe from the most devastating portions of the disease in terms of those organs that can cause loss of life, we don't stop treatment there. We would want to continue directing treatment towards symptoms like these. So these are good reasons to advance therapy. And I don't know your specific case. I'm so sorry you're experiencing it. But there are therapies that are dedicated specifically toward that. There's an FDA-approved therapy for ulcers from Behçet's, both in the mouth and the genital area. It's called apremilast, is the generic name, apremilast, apremilast. There's lots of topical therapies. There are plenty of other oral therapies. But what I would encourage patients to do is be your advocate. Some doctors are uncomfortable asking about this area. So it's important to be your own advocate. Let the doctor know there are important aspects of my health that are unaddressed, and I want to continue treatment on these areas. And then, if you need to, seek out, there are experts in this condition depending on where you live. There's lots of centers that are used to taking care of complex cases scattered all across the country. So, if you need, look for those specialist care, because having continued involvement there it would be a great reason to continue advancing therapy. I'm sure your doctors have been doing that, but it can be difficult. So keep being your own advocate. That needs to be addressed.
Thank you so much for addressing that question and so many others today. It's interesting to me that the skin issues with vasculitis are one of the most talked about topics, but one of the least that we actually have answers for. So this really addressed a lot of answers, and we appreciate you, Dr. Falk, for giving us your time today and doing that. And the Vasculitis Foundation will continue to help us with putting these webinars out there, and we appreciate them too.